Welcome back to CE Solutions. This is Volume 2 of Pain Management in Pediatrics. My name is Caleb Frady. I'm a full-time EMS educator and a part-time paramedic here in North Carolina. At the end of this session, the participant will be able to identify the prevalence of pediatric pain management and examine barriers to effective pain management, describe pharmacological pain management in pediatric patients, summarize ongoing monitoring and management of pediatric pain, and lastly, illustrate advanced pediatric pain management and assessment through simulated case study. Before we can learn more about how to assess and manage pediatric patients in pain, it's important that we take a moment to understand the prevalence of pediatric patients in discomfort. In the United States, about 5 to 10% of 911 transports represent pediatric encounters. And we can see right off the bat with this that pediatric patients make up a relatively small portion of our total call volume. But an important distinction, however, is that 20% of those encounters are pediatric patients who are experiencing moderate to severe pain. So while a pediatric encounter may be less frequent, there's a high likelihood that our pediatric patients in the field are experiencing at least some level of painful discomfort. Next, we can look at a large systematic review from Sao et al. In 2024, where they reviewed 270,000 EMS records. And what they found was in that children under the age of 15 with obviously painful injuries, such as a fracture, burns, and penetrating injuries, 19.7% were ultimately treated with pain medication. In the same study, they noted that only 6.4% of children under the age of 3 with similar complaints and injuries received pain medication. And this is a concerning trend from this study because our youngest and most vulnerable patients, according to Sao et al., are not receiving the pain management that they deserve. And this really sets up the rest of our discussion and our lesson on how important it is for us to be able to recognize a pediatric patient in pain and treat accordingly. Access to pain management is a fundamental human right, and as pre-hospital providers, it is our duty and responsibility to assess and treat patients who are in pain in the field when we encounter them. And looking back at Sao et al.'s study from 2024, we can see that as pre-hospital providers, there is a gap in the percentages of pediatric patients that receive analgesia. We also start to see that access to pain management is not equal across all patient populations. Donfirio, Odman, and Finney report that in pediatric patients under the age of 15 experiencing pain, only 8.7% of Black patients received pain management, compared to 22.4% of white patients. So this isn't necessarily a small gap, but this is a significant difference in pre-hospital delivery of pain management. And this reinforces why education such as this is so important, that it's not just about knowing how to treat a pediatric patient in pain, but it's recognizing factors that can influence whether or not we treat pain, understanding our own implicit biases, provider perceptions, communication barriers, and system-level challenges that can compound these disparities. And as providers, it's our role to be unbiased and to assess every patient every single time. And when a patient is experiencing pain, it is our duty to provide pain treatment. As paramedics, we have a responsibility to recognize pain, assess pain appropriately, and treat it effectively, especially in our vulnerable pediatric patients. And so through understanding these barriers to pain management and factors that may influence our decision making, such as our own implicit biases, we can be better providers and advocate for our patients. This really brings us into our discussion on the barriers to pediatric pain management in pediatrics. And Whitley et al. In 2021 identified two major barriers that contribute to our lack of pain management in pediatrics. They note a lack of experience in caring for pediatric patients and a concern about punitive punishment for making an analgesic error. And the second point is a very real concern, because when a provider feels like they're going to be punished when they make a mistake, then they're less likely to treat pain altogether. And we know from our previous discussion that the percentages of pediatric patients that receive pain management is relatively low when you look at the total amount of patients that we encounter who are in pain. There are some other additional barriers that it's important for us to discuss. One is the inability to assess pain. In pediatric patients, and especially younger children, they may not be able to clearly communicate what they're feeling, and that uncertainty can make providers hesitant to administer analgesia. And as we learned in Volume 1, a good assessment and recognition of pediatric pain is the first step in managing their level of discomfort. Next, we have hemodynamic instability. And this really means that when a provider deems that a pediatric patient is unstable, we may withhold pain management out of concern that it could worsen the patient's condition. And this highlights the importance of resuscitating first and still providing pain management when it's indicated. They also noted that the masking of symptoms was a reason providers said they may withhold pain management in pediatric patients out of concern that it could interfere with assessment findings, particularly in cases involving abdominal pain or trauma. Poor ambulance suspension was noted as a barrier to pediatric pain management, and while I understand that trying to obtain an IV and draw medication up in the back of a moving ambulance can be difficult, it is our job as providers to be efficient with these skills, and it is acceptable for us to pull the ambulance over and control our unit so that we can administer the treatments our patient needs before resuming transport. Access to opiates was a concern noted in their study, and this is really going to depend on the system, the availability of medications, storage concerns, and even provider comfort with administering this medication. So there's a lot of variables that go into access of opioids other than just having them or not having them. Difficulties with IV placement was also noted, and we know that pediatric IV cannulation is a very challenging skill, and it's one that often fails, and it's one we don't do very often because pediatric encounters make up a small portion of our total patient encounters. And that may cause a provider to not obtain an IV and thus not provide pain management because we're unable to gain that access. And lastly, Sawad Al noted that caregiver refusal or lack of knowledge of EMS capabilities was a barrier to pediatric pain management. Sometimes parents and guardians refuse pain medicine, maybe out of fear that the medication may cause their child to become addicted to that opiate, or they don't fully understand that EMS has the capability to effectively manage their child's pain. And as providers, it's our job to educate the caregivers on why we need to give these medications to help ease their child's discomfort. And in some cases, it may involve letting the parents know that we have these medications at our disposal. And as we move through this lesson, we're going to talk about some of the different ways that we manage pediatric patients in pain. And in some cases, a multimodal approach to pain management is what's necessary to truly manage our patients' level of discomfort. The question from all of these barriers is, how do we address them? One way we can do this is through high fidelity simulation training that mimics pediatric calls, encourages decision making under pressure, and pushes a provider to actually use the tools that are available to them, such as intranasal medications, to help bridge the gap in understanding that for most, if not all of these barriers, there is a way for us to adapt to them and manage our patients more effectively. Saladel also noted as a possible solution that providers emphasized that there was significant value in reviewing case studies. So learning from real calls and how other providers treated patients was able to build clinical judgment in a way that a simple lecture cannot do. And lastly, with this slide, Sawad Al also identified some of the factors that increased the likelihood of a pediatric patient receiving analgesia, and that would include the use of intranasal narcotics, longer transport times, vital signs that clearly suggest significant pain. However, we know that vital signs are subjective in pediatric patients and not as reliable in most cases, and the provider's desire to stabilize the patient as some of the areas that encourage pediatric pain management. And these are areas that we can focus on strengthening to increase the amount of pain that we manage in pediatric patients. So make sure to review your local protocols, revisit how to assess pediatric pain, and what your treatment priorities are. And more importantly, start advocating for and incorporating pediatric pain management into our high fidelity simulation trainings. I want to take a minute and circle back to opioids masking symptoms, especially in pediatric patients in pain. I know that at least my time in pre-hospital medicine and in education, this hasn't been something that we have taught, but it did still show up in some of the recent studies surrounding the barriers to pediatric pain management, so I want to address it. In 2019, a research study found that there's no significant difference in the correct or incorrect diagnosis of acute abdominal pain when opioid analgesia was used. And they also concluded that any type of opioid analgesic can be used safely for acute abdominal pain without the risk of impairment of diagnostic accuracy. So, this very clearly tells us that not treating a pediatric patient in moderate to severe pain with opioid medications is the incorrect practice, and that these medications can be used safely in patients experiencing abdominal pain and other medical complaints that can cause pain without limiting the hospital's ability to diagnose and treat their injury or illness. So please adopt this as our best practice, where we should treat patients in pain while continuing to assess their level of discomfort. And in that case, we're providing the best, highest quality patient care that we can. So we spent some time talking about the prevalence of pediatric pain, looking at some of the barriers that pre-hospital providers note as to why we don't manage pediatric patients in pain. And now I want to focus on some of the different routes of administration that we can provide analgesia to our patients. The first and probably the best way to give a pediatric patient pain management is the intranasal route. The intranasal route helps to overcome a lot of the barriers that are noted to pediatric pain management, such as difficulty with IV cannulation mainly, and safety concerns surrounding administering these medications. So we know that starting an IV can be really difficult in a pediatric patient, and it's not the type of IV stick that we routinely have the opportunity to do, so our skills with this patient population in many cases can be lacking. McDonald et al. In 2025 conclude that intranasal fentanyl is superior to oral morphine in pain management of pediatric patients with long bone fractures. So this helps us to feel confident that the intranasal route is a proven, safe, and effective way to administer analgesia to our pediatric patients, and in some cases can provide better pain control to other routes of administration. And then perhaps the most glaring benefit to the intranasal route is that IN fentanyl has been shown to significantly reduce the time to pediatric analgesia. So if you imagine a case where you have a pediatric patient that is in severe pain with a long bone fracture, and the amount of time that it would take for us to gather our IV supplies, place our tourniquet, look for a vein to cannulate, go through the process of starting the IV, dealing with patient anxiety, providers watching their child writhe in pain due to a severe injury. We can skip all of that and go straight to an intranasal route that doesn't hurt, allows us to very quickly administer the medication, and it's proven to be effective in managing their pain. And in my practice, the intranasal route has worked really well for pediatric patients with extremity fractures, as it's able to get the pain medicine administered, allow it to work quicker, and that really helps you to incorporate other ways to manage a patient's pain, such as comfort measures and splinting to complete our pain management priorities. And this can be hard for providers to change our mindset, as we typically associate obtaining IV access as one thing we need to do before we can give medications. But it's important for us to apply critical thinking to this and recognize that there's other ways that we can give medications, and we should do so strategically to meet our treatment goals. Some of the advantages and disadvantages of intranasal medications. Well, for the advantages, intranasal medications, like we talked about, allow for faster administration. They have pretty good bioavailability, and they require significantly less technical skill when you compare that to the process of starting an IV. In pediatric patients, these advantages matter because A relatively painless procedure compared to a needle from an intramuscular injection or an IV helps to eliminate adding additional painful stimuluses before it's really necessary. There are some limitations to be aware of with intranasal medications, one being that the volume of administration is limited, which can affect dosing, especially in larger or heavier pediatric patients. The absorption of the medication can be affected by factors within the nose, such as nasal congestion, the use of vasoconstrictors. So if the child's had a nosebleed and has been given Afrin or something like that, that can affect how the medication is absorbed. And in cases of facial trauma or active epistaxis, may contraindicate this route of administration. So from what we've discussed this far, we know that IV access is difficult and it delays care in pediatric patients. As providers, we tend to hesitate when it comes to managing pediatric patients in pain, and all of this prolongs the time to begin treating their pain with analgesia medications. The intranasal route helps to address all of these barriers, and it's noted to be fast, effective, and it's supported by evidence. The intranasal route should be considered our preferred first line for pediatric pain management in most pre-hospital situations. So this doesn't mean that we would never use other routes of pain management, such as intravenous, intramuscular, or even oral medications, but it does mean that in some cases the intranasal route is the best choice to treat a patient in pain quickly and effectively. I'm not going to spend a lot of time on the actual process to start an IV in a pediatric patient, but starting an IV in a child 3 years of age or younger is extremely difficult in the field, and our success rate for pediatric IV cannulation is relatively low. For me anyway, this aligns with some of my field experience where it is difficult to start IVs in infants and even school age children, especially kids that are scared of needles. And it takes an experienced provider to be able to manage that scenario and start an IV. We can look at some of the data, and Samaki et al. Report that IV attempts were only made in about 17% of pediatric encounters. Of those attempts, just 1% were in patients less than 1 year of age, while 75% occurred in adolescents who have more adult-like anatomy. So the amount of IV sticks that we're obtaining in the field as pre-hospital providers in infants, toddlers, preschoolers, and school-age children is very, very few attempts. This tells me that as providers, we're avoiding IV access in younger children, and in many cases, that's because we simply don't have the justification to start an IV unless the patient is in pain, and that we're more likely to start an IV in an older pediatric patient because we feel more comfortable with that skill. So we should choose the most appropriate route of administration when deciding how to treat a pediatric patient in pain. But it is unacceptable for us to say that we're not going to manage a pediatric patient in pain because we are unable to get an IV. So please make sure that you review and follow your local protocols on the different routes of administration you have for pediatric analgesia. Nitrous oxide, often referred to as laughing gas, has been shown to be safe and effective in treating acute pain. A major advantage to nitrous oxide is that it has minimal impact on a patient's respiratory drive and hemodynamics, making it a relatively safe option for pediatric pain management. Nitrous oxide is unique in that it provides multiple effects at once with analgesic, anxiolytic, and anesthetic properties. So it means that it's able to help a patient's pain, reduce anxiety, and this is especially useful in pediatric patients. You can see it used for things like fractures, dislocations, burns, or even to help facilitate painful procedures such as IV cannulation. The mechanism of action of nitrous oxide's analgesic effects are thought to come from stimulating the release of endogenous opioids that act on the mu receptors, producing pain relief that is similar to that of morphine. Its anxiolytic effects are similar to that of benzodiazepines through their actions on the GABA A receptor. And while nitrous oxide does have anesthetic properties, they're considered relatively weak and involve both GABA A and NMDA receptor activities. For pre-hospital providers, a major advantage to nitrous oxide is how quickly it works. Because nitrous oxide is inhaled and absorbed through the alveoli, it has a very rapid onset. The effects of this medication only last as long as the patient is inhaling it, and once the medication is removed, recovery is very quick back to baseline. So if we do have a patient that starts to experience negative side effects from this medication, simply stopping the medication and removing it can help clear up those side effects. Common side effects of nitrous oxide would include nausea, vomiting, dizziness, and a sense of euphoria. And these side effects are generally mild, but it is something that we would monitor closely when administering this medication. And because this is a self-administered medication, the patient has to have an intact mental status and be able to hold or tolerate the medication's mask. And this can make it very difficult to give this drug in very young children who are unable to hold the mask or have a lot of fear and anxiety from the device itself if it's too intimidating. So it may not be useful for all pediatric patients, but it does have a group that it is very useful in. Nitrous oxide should be avoided in conditions involving air trapping or expansion. This would include a suspected pneumothorax, decompression, illness, certain types of head injuries where it may increase intracranial pressure, and it's also avoided in undifferentiated abdominal pain. And the reason it's avoided in these cases is because nitrous oxide can diffuse into gas-filled spaces and increase the pressure within those spaces, and that increases the risk of ischemia or perforation. So when nitrous oxide is inhaled through the alveoli, it follows gas laws from high concentrations to low concentrations, and that's how the medication gets into the blood and is distributed throughout the tissues. But it enters faster than nitrogen can leave the tissue, and that results in increased volume and pressure within closed gas-filled spaces. Nitrous oxide also potentiates other central nervous system depressants. So this would include opioids and benzodiazepines. So because of that, we do not combine these two therapies, and if we determine that a patient needs narcotics, then the nitrous oxide should be discontinued first and allow the symptoms to reside as we monitor the patient before we proceed with another route of pain management in our pediatric patient. Nitrous oxide is a good pain management option in pediatric patients when we're looking for something that has a rapid onset, a short duration, and minimal effects on a patient's respiratory system and hemodynamics. But it's not for every patient, as the patient does have to be able to tolerate holding or having the mask for the medication placed on them. Next, I want to spend a couple minutes talking about how we would administer this medication. In many EMS uses, nitrous oxide comes in a 50-50 concentration, where it's 50% nitrous oxide and 50% oxygen. And when it's administered, the patient's getting both of these gases, where the nitrous oxide is producing the analgesia and the patient is receiving an adequate concentration of oxygen. This balance helps to prevent a hypoxic gas mixture from being delivered to the patient. So nitrous oxide on its own can create hypoxia. The delivery system of the medication, like the example you're looking at on the screen here, has some built-in safety mechanisms. So if the oxygen supply becomes depleted or malfunctions, then the nitrous oxide automatically shuts off. And that's what prevents the patient from receiving a hypoxic gas mixture. Next, many of these systems are designed to increase oxygen delivery if the patient begins to breathe shallow as a result of the medication, and that helps to maintain adequate oxygenation. This medication is typically delivered through a handheld demand valve system, so that means that the valve only opens when the patient generates an inspiratory effort. So as the patient places it up to their mouth and takes a breath, then they begin to receive the medication during that inspiratory cycle. This helps to limit over sedation and prevent the patient from becoming too drowsy, as if they do, then they'll simply stop inhaling the medication and the effects will wear off. So it's really truly a self-administered medication, which is why it can work well for some of our older pediatric patients who are able to follow those instructions. Nitrous oxide is a pretty dense gas, and that means that it's going to accumulate in enclosed spaces, such as the back of an ambulance. And if ventilation is poor or the ventilation fan is not turned on in the ambulance, then this medication can build up to the level that it starts to affect providers. So, in administering nitrous oxide, it is imperative that we ventilate our unit very well. So, the vent fan is on, maybe even open a window so that the excess medication can escape from the enclosed back of the unit. While nitrous oxide is considered an ALS medication, in many local protocols it's been adapted to BLS providers. So regardless of your certification level, nitrous oxide has a lot of utility in pediatric pain management, and it's a relatively safe medication that is well tolerated in patients because it's self-administered and the device itself has safety mechanisms built in. It can be a safe medication that can help treat pediatric patients in pain. Regarding IV acetaminophen, in 2024, Osorio et al. Conducted a large comprehensive review of 2,344 studies comparing intravenous and oral acetaminophen for pain management. Their findings challenge a common assumption in prehospital medicine that IV medications are more effective than other routes of pain management. Ultimately, they concluded that the evidence does not support the superiority of administering acetaminophen IV over the oral route for pain management. The study did highlight that intravenous acetaminophen reaches peak plasma concentrations more rapidly compared to the oral route, and that can translate to a quicker onset of analgesia that may be beneficial in many patients who are experiencing acute severe pain where immediate pain relief is desired. However, when you compare this to our pediatric pain management, we know that that decision to provide an IV medication is really going to be influenced on time, environment, patient cooperation, and ability for us to obtain an IV within a relatively short period of time or at all, depending on patient's anxiety with a painful procedure. Toradol or Ketorolac is another medication that can be used for pediatric pain management, and it's considered an off-label use as currently the FDA has not cleared it. However, national standards and local protocol can still allow it to be given to pediatric patients in pain. It is important that it's not recommended to be used in patients under the age of 2. Ketorolac is indicated for the acute management of moderate to severe pain, and it works well for musculoskeletal pains, sickle cell crisis, and migraines, as well as an option other than opioids. And in some cases, a parent or caregiver may not want opioids administered to their child. And this is a way for us to still treat pain without using opioids, or a way for us to treat pain in conjunction with opioids and really provide a holistic pain management approach. Ketorolac is considered more potent than other NSAIDs, and a single dose for a pediatric patient is zero point 0.5 milligrams per kilograms once, not to exceed 15 milligrams. Ketorolac works by blocking both cyclooxygenase 1 and cyclooxygenase 2 receptors, inhibiting the creation of prostaglandins. And through this inhibition, it's able to decrease pain, fever, and reduce inflammation. Because of its mechanism of action in inhibiting both cyclooxygenase 1 and 2 pathways, we would avoid this medication in patients with an increased risk of bleeding or GI complaints, as Ketorolac does have antiplatelet effects that can increase bleeding, as well as this medication being associated with peptic ulcers. We would avoid this medication in patients with hypotension that's due to renal toxicity or a child with poor renal function. We wouldn't want to give this medication to. Allergies or sensitivities to NSAIDs would also be contraindications. And it's important that when administering Toradol and any pre-hospital medication that we pay attention to the concentration of the medicine that we have before administering. It's very easy for us to get in a routine if our agency has carried 15 milligram vials as long as we can remember, but then there becomes a medication shortage, and suddenly we're stocking 30 milligrams per milliliter vial. So you can see that if we don't pay attention to what the vial is and how much medication is in there, we can inadvertently overdose our pediatric patients. So we want to be very precise and look at our vial of medication before administering this medication. Opioids are one of the most common ways for providers to treat pediatric patients in pain, and the analgesic effects are produced through agonism of opioid receptors in the central and peripheral nervous systems. Prehospital opioids, such as morphine and fentanyl, are primarily going to bind to the mu receptor and are considered strong opioids. Some of our pediatric considerations are that opioids can lead to nausea, vomiting, altered mental status or altered mood, hypotension, and respiratory depression. So we should be prepared to monitor and address these symptoms that may arise after administration. That may include administering an antiemetic medication such as Zofran to treat the side effects of nausea secondary to opiate administrations, and monitoring a patient closely for hypotension and respiratory depression. Other common side effects of opioids would include constipation and itchiness. Opioids are an acceptable pre-hospital intervention for the treatment of pediatric acute pain. Morphine and fentanyl are our two primary opioids, and we shouldn't be scared to treat our pediatric patients in pain with opioids, as these are effective medications that can be used safely when given according to our local protocols. In the case of morphine, it can cause histamine release, and this can lead to vasodilation that contributes to hypotension secondary to morphine administration. Some other factors that are associated with opioids causing hypotension, this would include fentanyl as well, can include a reduction in alpha receptor stimulation within the sympathetic nervous system. So that affects the size of our blood vessels. Nitric oxide release, which is a potent vasodilator. So in morphine's case, that would be caused by the histamine release, as well as these medications stimulating a vagal response, leading to decreased cardiac output secondary to that response. So because of these effects, with morphine being associated with hypotension due to histamine release, we wouldn't want to give this medication to a patient who is hemodynamically unstable. And as ALS providers, we would need to understand that we would need to resuscitate first. So that might include providing oxygen, ventilating, providing IV fluids in severe cases. And it's also important to highlight that morphine needs to be administered intramuscularly or intravenously. This is not an intranasal medication. Fentanyl, on the other hand, is the most common way for us to treat a pediatric patient in pain, and it has been shown to be effective in treating burns, fractures, and patients in abdominal pain. Fentanyl has less hypotensive effects and is safer to use in children with hyperactive airway diseases. And we talked earlier about the intranasal route and how it's effective to get pediatric analgesia quick and painless in pediatric patients. Fentanyl is one of the primary medications for that. And Kuniko et al. In 2023 concluded that intranasal fentanyl has been shown to be as effective as IV morphine. A typical dose for fentanyl is 1 microgram per kilogram with a max single dose of 100 micrograms. But always follow your local protocols to determine what your minimum and your maximum dose is of narcotic medications such as morphine and fentanyl. Anytime that we provide a patient with an opiate medication, it's essential that we monitor them very closely. We also should understand that pulse oximetry is not an effective way to measure hypoventilation, apnea, and hemodynamic instability, mainly because there's a lot of factors that can influence this assessment tool's reliability. Capnography, however, is going to be our best indicator of hypoventilation and is superior than pulse oximetry measurement alone and should be utilized anytime we administer opiates to a patient. We also should assess the patient's pain severity
before and after medication administration, as well as after interventions, and just before arrival to the emergency department.
It's Saturday morning, and we're dispatched out to a football field for a child who has suffered a big hit. Our dispatch notes tell us that we're responding to a 7-year-old who's been injured while playing football. As we arrive and we walk onto the field, we can see that there's a large crowd that's gathered of spectators, the patient's parents, other players, as well as coaches and athletic training staff. As we get closer to the crowd, a coach walks up to us and says that this patient took a significant blow from the side and immediately started crying and holding their left arm. And when they got up to them, you could tell that there was obvious left arm deformity. So as we begin our assessment, it's going to begin with our primary assessment because our first goal is to ensure that there are no immediate life threats that we need to manage. We find that the patient is crying loudly and able to look at us and even tell us his name as we approach. That tells us that his airway is patent and protected. This patient's appearance, according to the pediatric assessment triangle, this really tells us that the crying and the facial grimace are key indicators that this child is in significant amounts of pain. As we assess breathing, the patient has a rapid and regular respiratory rate with equal chest rise and fall on both sides. For circulation, we feel a rapid and bounding pulse, and the patient's skin is warm to touch and diaphoretic. All of these signs and symptoms from our primary assessment point towards some moderate to severe level of distress, but none of them are indicative of immediate life threats. So because of that, we can go ahead and proceed forward with our patient assessment. Since this call involves a traumatic injury and the mechanism or the potential of injury due to being struck from the side like this, there could be other injuries aside from the patient's arm that we haven't felt yet. So in this case, we do a rapid trauma exam. We use athletic trainers on the field with us to assist in removing some of the patient's protective devices, such as their shoulder pads, their jersey, and even their helmet if we feel it's appropriate. So after we have appropriately exposed not only the injured area, but other areas of the patient's body that we need to assess, we can begin our head-to-toe assessment.
And when we do our head to toe assessment, the only injury that we find is an obviously deformed humerus.
In addition to the patient's initial presentation with crying, complaining it hurts, and facial grimace, are all indicators that this patient is in significant amounts of pain, and at some point in our care, we may need to address that. As we continue with this case, we could have delegated vital signs to our partner when we arrived so that as we're conducting our assessment, we can get our vital signs simultaneously, and that can help better inform the method or modality that we use to treat pediatric pain. And our partner comes back with a heart rate of 128, a respiratory rate of 25, a blood pressure of 104/68, and an oxygen saturation of 99%. All of this brings us to our fifth vital sign, which is our pain assessment. In this case, with the patient being 7-year-old, they can self-report their pain to an extent, but not in the same way and not as reliably as an adult would. So the Wong-Baker Face Pain Rating Scale is the most useful tool to rate this patient's pain. When using this tool, it's important that providers don't simply look at the patient's facial grimace and then manually assign a number themselves. Rather, we should present the patient with the Wong-Baker Face Scale and allow the child to select the face that matches their pain level. And flexibility is important with this. Our pain assessment should not delay our care, rather it should inform and support it. In this case, the patient immediately points to the hurts worst face on the far right of your screen, indicating a 10 out of 10 pain level. In this case, we've identified and isolated,
Humeral injury.
assessed our patient. We've established that this child is in severe pain. So our question becomes, how do we actually begin to manage this patient's pain? What are some of those priorities and what are the best ways to do that? Well, from volume one, we learned that pain management in pediatrics is not simply just about medications, right? It's about our basic level skills. So we can start with a position of comfort having a family member try to comfort the child, get them into a position where the pain isn't as much or is at least bearable. That may even include splinting with a sling and a swath. We should start with those types of things first as we prepare ourselves to move into ALS pain management. Considering this is a football injury, there are some considerations to discuss there. Our athletic trainers and other professionals on scene at these types of events are going to be our go-to when it comes to how to remove and defeat some of the straps and mechanisms that hold that equipment on. So utilize those providers to our advantage to help us safely and efficiently remove athletic equipment when needed. But also keep in mind that in this case, simply removing the equipment could be painful. So it is acceptable for us as providers to leave that equipment in place, begin pain management, and then remove it later. A lot of it comes down to what we're actually presented with when we do get this type of call. So after we've addressed some of our basic ways to manage pain, we can start to think about ALS pain management. And ideally, we want to start ALS pain management before we start to move the patient's arm around a lot, before we stand them up and put them on the stretcher and put them in the ambulance, and definitely before we begin transport. This is not the type of call that we should begin our transport driving down the road before we've administered some sort of comfort measure through pain medication to our patient. Intranasal fentanyl is likely the best option in this case. The patient's 7 years old, in severe pain, probably having difficulty sitting still. Obtaining an IV in this case is probably not going to be the fastest and most efficient way to begin treating the patient's pain, as well as an IV causing additional pain through a stick. Even an intramuscular injection can add more anxiety and pain to our patient who's already in severe pain. So the intranasal route, as we talked about earlier, is a fast, effective, and easy way to provide pediatric analgesia and is really a good way for us to initiate that pain management as we continue our assessment, movement to the ambulance, and then if we deem it's appropriate, we could obtain an IV once we've managed the primary source of the patient's pain. Our dosing for fentanyl in this case is 1 microgram per kilogram. Our max single dose would be about 100 micrograms, and our max total dose is 200 micrograms. And this can vary between local protocols, so please follow your dosing regimens. If we were to say that we have a patient that's 50 pounds in this case, that's going to be roughly 22 kilograms. So we would give this patient about 22 to 23 micrograms of fentanyl intranasally. Fentanyl may not be the only medication that we could give this patient to manage their pain. In an agency that carries nitrous oxide, this might be a good option to begin managing the pain, especially if the patient's caregivers deny the use of narcotics or are uneasy about us providing that type of pain management to their patient. Please keep in mind that we would avoid mixing nitrous oxide with opioids. If we end up giving them both to this patient, we would administer nitrous oxide, stop that procedure, allow that medication to wear off, and then we could administer the fentanyl. We also have options for NSAIDs, such as IM Toradol and even IV acetaminophen in an agency that may carry that and it's approved in pediatric patients. The dosing for those can vary. Your typical Toradol dose for a pediatric patient is 0.5 milligrams per kilogram to a max of 15 milligrams. And this is an intramuscular injection. So we need to manage that depending on the patient's comfort level with needles. If it's going to cause too much additional pain and anxiety, then it is acceptable for us to withhold that treatment. The next big question is, do we need IV access? Well, in this case, it's an isolated extremity injury. So our IV access really becomes more situational than just mandatory. So if we start with IM fentanyl and we achieve good results in pain management, and that's able to manage the patient's pain effectively, and maybe we proceed forward with intranasal administration a second time to manage the patient's pain. Because we've given a narcotic in this case, we do need to do some close monitoring. This would include obtaining an EKG, monitoring the heart rate, the patient's respiratory rate, and mental status very closely, as we know that narcotics can depress a patient's respiratory drive. Fentanyl is not as associated with hypotension as morphine is, but we should still monitor the patient's blood pressure closely and be prepared to intervene if hypotension occurs. This could be an indication for us to start an IV and provide the patient with a fluid challenge to help offset the hypotension caused by fentanyl or other narcotics. And the most important monitoring tool is end-tidal CO2 or capnography, as this provides us with real-time breath-to-breath monitoring of our pediatric patient. And our last question, how often will we reassess pain? Well, pain management is an ongoing intervention and is not a one-time treat and done. And it really depends on how long our transport is and how significant the patient's pain level is. In this case, we would reassess pain every 5 to 10 minutes at the same intervals that we assess our vital signs. And when we reassess our pain, if the patient is still uncomfortable and their pain is increasing once again, then we could redose fentanyl or begin to look at other ways to manage pain. But it's important here that our goal is not to eliminate pain entirely. Our pre-hospital goal with pediatric pain management is to make the patient more comfortable and allow our call to be more manageable so that we can safely transport our patient. And anytime we have a pediatric patient in pain, don't overlook some of the simple comfort measures, such as their favorite game, favorite toy, or a video they like, even something as simple as a pillow to help support the extremity that's injured, in this case the arm, can truly help limit the amount of pain or discomfort the patient's feeling. So to conclude this case, we were able to manage this patient with 2 doses of IN fentanyl en route to the hospital with about a 20-minute transport, keep the patient comfortable with a sling and a swath and a pillow to support their arm, as well as a caregiver in the back to help console and calm some of the patient's anxiety in dealing with this injury. And ultimately, it was a good outlook and it was an effective pre-hospital way to manage pain. I have one more case study for us to look at before we conclude our lesson on pediatric pain management. In this case, we're dispatched out to a pediatric patient with a complaint of abdominal pain. In this case, the patient is about 1.5 years old. And when we arrive, the mother reports a very specific history for this patient's pain. She reports sudden episodes of intense crying while the child will pull their knees up to their chest, almost in like the fetal position, and that these episodes last for about 5 to 10 minutes before the child becomes calm in between them. The mother also reports that the patient has been vomiting, to which we respond with, what does the vomiting look like? And she says that it's been bilious in nature. That's a red flag for us because that could indicate some sort of intestinal obstruction in an infant patient. The mother also describes behavioral changes where her child has been more lethargic and their skin color has looked more pale than it normally does. So we can see that this case is appearing to be more than just a simple stomach bug with vomiting and diarrhea that absolves on its own. And our patient is presenting with symptoms that are indicative of episodes of severe pain. As we move into a physical assessment, we can note a distended abdomen with guarding. Our vital signs reveal a heart rate of 158, a respiratory rate of 30, an SpO2 of 99%, a temperature of 99.2, and a cap refill in less than 2 seconds. Now, I didn't spend a lot of time talking about the primary assessment in this patient, but a patient of this age, we would use our pediatric assessment triangle to really inform the majority of our primary assessment before we ever need to touch the patient. And that pediatric assessment triangle can be further strengthened through questions to mother about the child's normal activity level and what's different about today. So in this case, some of the things that are concerning are the elevated heart rate, the patient's respiratory rate, as well as their skin color changes and mental status changes. And while the patient's perfusion status still looks okay, it's concerning because there's clearly some sort of abdominal emergency occurring that is not only causing severe pain, but has the potential to cause a critical illness and even death. Our treatment priorities initially are going to be to provide oxygen as needed based on our patient's presentation. And when we put all the patient's symptoms together that was reported, this is highly concerning for intussusception, which is a condition where one part of the bowel telescopes into another, causing an intestinal obstruction. That can be very painful. Given this patient's age, the question then becomes, what pain assessment scale do we use to manage our patient's pain? And in this case, the FLAC scale is the most appropriate because it allows us to manage and gauge the patient's pain without them having or being able to self-report it. For face, we would give this child a score of 1, and this means that the child is occasionally grimacing or frowning, but not in constant distress. So between episodes, the pain is relatively gone, but during episodes, it's very severe. For legs, we could give a score of 2, as it was reported that this child is drawing their legs up towards their chest. That's a classic sign of abdominal pain. For activity, a score of 1 is most appropriate. The child is tense or shifting positions, so struggling to get comfortable, but not completely rigid or arched, unless it's during a painful episode. So in this case, we would go with a 1. For cry, we would assign a 1, and this would mean that the child is moaning or whimpering intermittently. Fits best for this patient's presentation where there's intermittent periods of severe pain followed by discomfort in between that's relatively minor. And lastly, consolability. In this case, we provided 2 because according to the mother, during these episodes, the child is difficult or impossible to console, which is why we would assign a 2. That brings our total FLAC score pain rating up to a 7 out of 10. It's important to note that we achieved this based off the patient's developmental age and the mother's report. And this really highlights that pain management in pediatrics, in many cases, is not verbally reported, and rather it's gauged through a behavioral assessment of our patients. So, with this case in whole, the most concerning things are the complications from intussusception. So managing shock, airway breathing, circulation, IV access, fluid management, patient comfort are going to be our priorities. And pain management plays a role in our patient's care. It just comes after we've managed some of those higher priorities that I discussed. So if we were to skip forward in this care to when we're at a point to actually begin to manage this patient's pain and comfort level, what medications are indicated? In this case, again, fentanyl is likely our best choice. It can be given intranasally, can be given intravenously. For this case, we've already obtained an IV. We're giving fluids to help support our patient. We can go ahead and administer a bolus of fentanyl to help with the patient's discomfort level. However, keep in mind, because the patient initially presented with some lethargy, we would need to very closely monitor the patient's respiratory status in this case and be prepared to ventilate or provide supplemental oxygen when it's indicated. Morphine is also an option in this case, the main drawback being it's more associated with hypotension. Now, what medications would we avoid for this patient? The first one is nitrous oxide. Nitrous oxide is contraindicated in cases of undifferentiated abdominal pain. So while we're pretty sure this is intussusception, we can't truly know based off our assessment, and there could be other causes of this abdominal pain. Nitrous oxide diffuses into gas-filled spaces and can actually make a bowel obstruction much worse, as it can worsen distension, can cause increased pressure, and ultimately lead to tissue ischemia. NSAIDs, such as Toradol, are also contraindicated in this case. They're contraindicated because they come with an additional effect of platelet inhibition, and that increases the bleeding risk for this patient when they do need to undergo surgery to correct the intussusception. So for that reason, NSAIDs are not indicated for this case study. Acetaminophen, depending on local protocols, may be indicated for pain in this case, as acetaminophen works within the central nervous system and doesn't have the same effects on the tissues and specifically the platelets that NSAIDs have. So as you can see, there's more than one way that we can manage pediatric pain, and in many cases, it's a multimodal approach with BLS maneuvers working our way and facilitating us into advanced life support treatment modalities of pediatric pain. And in this case here, we performed an assessment. We resuscitated first with IV and fluids and transport, and then we began to look at pediatric pain management. Compare that to the first case where the best practice was to initiate pain management to facilitate movement to the ambulance. And my takeaway for you all is that it's our duty to treat pediatric patients in pain. We should treat pain early and when it's appropriate, and not delay pain management to complete a perfect assessment or obtain a perfect pain rating from our patient. We should start with the least invasive ways to manage pain first, and that includes the most effective route of administration. And always consider the patient's underlying pathophysiology before initiating pain management. By doing this, we can avoid providing a medication to a patient that can actually complicate their injury or insult. And lastly, after we've provided pain management, this is an ongoing process to continue monitoring the patient's pain, monitoring the medication's effectiveness, and being able to adjust courses when necessary. Thank you for watching Pediatric Pain Management Volume 2. We'll see you next time.